All right, tigers, last one, best one, categorizing azotemias. Okay, just to review, an azotemia is an increase in BUN and or creatinine, and it's almost always due to a decrease in GFR. And we will see examples when it's not quite, but usually that's what's happening. There's three categories that we break it into: pre-renal, renal, and post-renal. So pre-renal are all the things before the kidney that can affect glomerular filtration rate. Mainly things like decreased plasma blood flow is a big one. Renal is kidney disease, so losing those tubules and losing those nephrons. And post-renal are things that are happening after the kidney from the ureters on down. Differentiating these guys. We use urine-specific gravity to differentiate between renal, pre-renal, and renal azotemias. Okay, so this is pre-renal azotemias. Our kidneys are unaffected. Our kidneys are still able to concentrate urine. So we usually have nicely concentrated urine-specific gravities. In renal azotemias, as our kidneys lose their function, they lose their ability to concentrate urine. So it's usually inappropriately concentrated, meaning that like it's more dilute. And the end game is when it ends up in isocynuria, which is that 1008 to 1012 range where the urine is at the same density as the plasma. So we use these two to differentiate between these two causes. In post-renal, we looked at clinical history and presenting signs. We'll talk about that in a few minutes as well to identify that pattern. But first up, let's talk about pre-renal azotemia. So things that are happening before the kidneys here. And the big one and the most common is dehydration. Also in this category are things like shock, hypovolemic shock, and cardiac insufficiency or decreased cardiac output. All of these things effectively decrease renal blood flow. And when the blood isn't flowing as fast and as nicely through the kidney, it decreases that glomerular filtration rate. The pattern that we will see here is we get oftentimes a mild increase in our BUN, and sometimes a mild increase in our creatinine. But our nephrons here are still functioning properly, and we will have well-concentrated urine-specific gravities. Okay, so we still have maintenance of the gradient here in the loop of Henle. We also have our collecting duct functioning appropriately, and our urines will be nicely concentrated. Okay, cats well over 1040, dogs, horses, and cattle, as we have talked about. The other thing that can happen, that is something that has nothing to do with the kidneys or anything urinary tract, is that there can be increased urea production. This is most commonly seen with an upper GI bleed. So something that's bleeding in the stomach or the duodenum. And it essentially, blood is really rich in proteins, and it essentially over time creates this really high level of protein intake. And what happens at the level of the liver is like these amino acids are coming in, it's doing its job of plucking off those amine groups and popping them onto urea and putting it out into the blood. We may see mild increases in our urea and nitrogen from that. We can also see it with endogenous protein catabolism. And in ruminants with decreased rumen motility. So keeping in mind that in the rumen, one of the things the microbes do is they take that BUN and they put it back in proteins. And if that process isn't working correctly, we're going to have a backup of BUN and increase there. So these guys don't have a ton to do with GFR, but they are other causes of things that'll increase BUN. So again, keep an eye on that urine-specific gravity. If it's nicely well and concentrated, we are like, those kidneys are doing their job. They are A-okay. Whereas with renal azotemia, and this is the other one that we do in contrast with this, we can have increases in BUN and creatinine. We often have increases in both. They can range from mild to very severe increases. And our urine-specific gravity is poorly concentrated, okay, or inappropriately concentrated, inappropriately dilute. So what's happening in this case? In renal azotemia, the disease is at the level of the kidney, and we are having a fall off of the number of functioning nephrons. Okay, so there aren't enough nephrons present to properly filter the blood. And what ends up happening is that the BUN and creatinine back up and into the blood and aren't being filtered at a proper rate, decreased glomerular filtration rate. Because we also have kidney disease present, the kidney's tubules are slowly falling off. The kidney loses its ability to concentrate urine. The end game for this is isocynuria. All right, so the kidneys, the concentration of the urine is exactly the same as the water. Okay, there's no change in that density. The kidney's neither added water nor taken away. It has just simply passed through and been excreted. When we have isocynuria, the patient is losing loads of water. Okay, the kidney is so important in that water retention process, and it can actually drive dehydration. And a lot of times these patients will come in dehydrated. You'll be like, you are a little raisin, your urine should be like 1060, really well concentrated, and you get this urine that's like 1008 or 1010 that coming back, that's very dilute. When this happens, because the kidney is just a pass-through, urine builds up a lot faster. You get a lot more urine in the bladder, and these patients tend to pee a heck of a lot more. That polyuria because they're losing so much water, they tend to be very thirsty and develop polydipsia. So many urine, polydipsia, many dipsia is drinking. Okay, so PUPD is what we will see with these. Post-renal azotemia is one that we are looking more for our clinical signs to diagnose, okay? So we will have an increased BUN, and we will have an increased creatinine, but a variable urine-specific gravity. There are two causes of post-renal azotemia. So urolithiasis, which is essentially stones, urine stones, kidney stones that have moved down the line, or stones that have formed in the bladder that have caused an obstruction, okay? It can happen in the ureters, those thin little tubes, or it can happen in the urethra, where the stone has become lodged and the patient is not able to urinate. It decreases the GFR because all that urine backs up all the way back through the nephron, and essentially the glomeruli are completely packed and nothing can pass through or exit. Okay. The classic example of this is the block TOM in feline lower urinary tract disease. Okay, so when they're on the litter box screaming, they tend to have large turgid bladders. They can be very, very sick if it goes over time. There can be a lot of metabolic disturbances associated with that too. But those are the things clinically that we're looking for. They tend to have this horrible yawl, and if you haven't heard it, you will at some point in your clinical rotations. That happens with these guys when they can't urinate. The other classic example on the large animal side is goat urolithiasis, but keep in mind this can happen in any species, and stones can happen across the board. The other post-renal azotemia is a slightly different variation on the theme. It is a uroabdomen, or uroperitoneum is the other term. And that's essentially when urine ends up in the peritoneal cavity. It can be secondary to urolithiasis. So if those stones are in there for too long, the bladder can potentially rupture, or urethra or ureter tear, and you can end up with a uroabdomen. It can be secondary to trauma, hit by cars, neonatal foals, things along those lines that end up causing some organ damage and rupture of the urinary tract. In uroabdomen, it's not so much that there's a decrease in GFR, but the stuff that the kidney has taken so much time to concentrate and filter to get rid of ends up back within the abdominal cavity, right up against the serosal surface, and it diffuses back into the blood. And so we will see increased BUNs and creatinines there. What are we looking for in uroabdomens? We're looking for distended abdomens. We're looking for fluid-filled abdomens. There are some electrolyte changes that happen that are very classical examples. We'll cover that more when you guys get up into clinical pathology. But that wraps up the three types of prerenal azotemia. I'm going to post some practice cases up on Canvas for you guys to differentiate between prerenal and renal and start applying those patterns to start working into that. And when we come to class, I will have some cases that we can walk through together. And this is Othello. He was one of my cats that's currently living with my mom during a huge snowstorm. Then I was back in Chicago. So, all right, talk to you guys soon.